Great. Well, good morning and welcome back to a terrific online workshop. I'm Dr. Robert Amler. I'm a former HHS Regional Health Administrator, Region 2, and currently Vice President for Government Affairs at New York Medical College and Dean of the School of Health Sciences and Practice in New York. We are kicking off this second panel with a series of short presentations to help us understand two things during and after federally declared disasters. First, how are the systems and networks of human and social services for children and youth affected? And second, how are these services delivered? We'll do quick introductions. All of our bios are in the briefing book, and let's get started with Shannon Christian. Shannon is Director of the Office of Child Care in HHS's Administration for Children and Families. Shannon, please begin.
So thanks for this opportunity. I appreciate being able to be part of the conversation. As you can see from the bio, I oversee the Office of Child Care, which administers the Child Care and Development Fund, which we call CCDF. Some people also call it CCDBG, so don't be confused. That's part of the funding stream, and then there's an entitlement piece. They come together, they become CCDF. So that's what I'm going to use today. The CCDF is an $8.7 billion block grant from the federal government to states, territories, and tribal grantees to help eligible low-income families pay for childcare for children birth through age 12. They also have to reserve a set of funding to improve quality for all children. That is a minimum percentage that has to be used for quality activities. And we'll mention that later because that can also be used in disasters. When we take that $8.7 billion and combine it with the money we get from state match and maintenance of effort, and also TANF transfers directly into that fund, it's an $11.7 billion block grant or funding source. So I think that I want you to remember that because it's a block grant, we're a step removed from the service providers, and that we are working through the states, territories, and tribal grantees. So when I say grantees in this presentation, it's those government-wide at that jurisdiction level that I'm talking about. We also permit that in that block grant a lot of flexibility to design the programs as those jurisdictions grantees would like, but in certain areas they are designing them within federal parameters. And in those areas where they're designing within federal parameters, those include provider payment rates, the parent copay amounts, the eligibility, and what group might be targeted, like teen parents or any subset that they may decide to focus on. Otherwise, they have a lot of flexibility. We also fund a lot of research and technical assistance out of that block grant. It's a set percentage that we can use from Congress. And with that, we fund a series of national TA centers that includes a staff person that's dedicated to emergency and disaster plan development and support. Those grantees are required to have disaster plans for preparedness, response, and recovery that include, on the preparedness side, policy and capacity to continue paying child care providers for eligible children when the child care program is closed due to a disaster. The response provisions need to include how grantees will use the assistance program flexibility in making changes to their child care assistance program. And then recovery includes building the supply of child care, for example, by providing grants to providers to reopen classrooms to serve additional children. So what do we do when a disaster occurs? First, we provide technical assistance to grantees. We help them understand and use the flexibilities available in their child care funds. And as Josephine Bias mentioned, we also partner with other Administration for Children and Family programs, other federal programs, and FEMA to coordinate support along with grantees, helping grantees identify others who can provide support, and we coordinate with national organizations such as maybe Save the Children, American Red Cross, and Child Care Aware of America. So there's a lot of coordination going on. Never enough, but it's one of our big roles because the actual on-the-ground activity is being done at the state level or tribe or territory in response to the planning that they had and the disaster at hand with all the help that we can provide, but they're in the lead. Now, I mentioned that we have flexibilities in how the block grant funding can be used to support disasters and emergencies. So let's walk through those. In an emergency or a disaster, a state, territory, or tribal grantee can change the eligibility or priority criteria for services. They can change the income threshold for being part of the funding, the subsidy. They can waive parent co-pays. They can broaden the definition of protective services to include the affected children. They can use quality dollars, which I need to explain. I did a little bit before, but these are the minimum percentage of the block grant that doesn't go to direct services or administration, that funds quality activities. And they can use that money to provide immediate childcare assistance to displaced families, or they can fund, as something that came up earlier that I wanted to bring up, they can, whether or not they're using the disaster funding or plan, they can, CCDF money can always be used to fund mental health consultants and trauma training as part of professional development. And so that is our link to the questions that were coming up earlier, and we need to do more to support that because I don't think enough of it gets done, even though it's an allowable use. Then also grantees can provide supply building grants to childcare providers. They can eliminate that quality spending percentage, that piece we talked about, and spend more money on direct services. They can request temporary waivers for extraordinary circumstances. And finally, which isn't under control, they can use their direct TANF dollars, which have fewer requirements than CCDF and might be better suited in some cases to some emergency function. Now, it's important to mention that a lot of these processes and changes may include obtaining waivers or doing plan amendments, which can be done retroactively to put these changes into place. And the details for all that are on our website, and they're mind-numbing, and I am going to let you do that on your own. Next, if you want to learn more about these flexibilities and related funding streams, you can look at this information memorandum on our Office of Child Care website that is posted there. And you can learn more, not just about the flexibilities, but the related funding streams. And you can find a shortcut to that by going to just find our website, and the cover photo, little girl washing her hands, very cute. There's something you can click on that says review the resources, and that will take you to mostly all our COVID resources, but in there is this information memorandum that's targeted at the flexibilities for any disaster. So that's helpful for you. Then you might be wondering about supplemental funding. And in a disaster or emergency, Office of Child Care can get additional funding. And recently, we did get $30 million in supplemental funding for grantees that were affected by federally declared natural disasters in 2018 and 2019. They had to go through an application process, but the funding was retroactive, and they just had to sort of document what they used or needed, and we were able to provide that. Now, that money is a first for us because we don't usually get supplemental disaster funding appropriated specifically for childcare or directly to us. So it's a new thing, and I think it's going to work better than hoping that the money goes to a partner agency, sister agency, and they share. So we're pleased with that. Then I want to talk a little bit. We did get $3.5 billion in CARES funding dollars for all grantees to address the COVID-related issues. But I also want to mention some other challenges that are not part of our emergency disaster plans at this point. This is a little bit outside, I guess I would say, our current piece. But we have new challenges that are not part of our current planning that find providers closed or offering limited services only to essential workers, and that was declared by state order. It wasn't their choice in a lot of cases. Others chose to close just because they weren't comfortable with the dangers of the virus spread. Many of those are still closed. Others are open, maybe serving still just emergency workers, or some serving the general public, but all with far fewer children. We also see that some money is going, although the money was directly for new demands on the child care system, such as serving children of emergency and first-time workers and helping sustain the child care industry. We know that it's also going to fund things like masks and gloves and hand sanitizer, cleaning solutions, and such things that are touched all the time. So it's a constant use of lots more cleaning equipment than anyone needed before, and it's hard to find now because everyone wants it. Or things like space dividers between napping children. So there's a wide range of things that money is going for. But I also want to talk about how the nature of childcare is changing. I think it's worth noting that parents are concerned about safety, and they're making decisions that influence childcare supply and demand in ways that aren't totally understood yet. And we see a bigger preference than before for small settings, such as family childcare homes or smaller childcare centers. And also, we are struggling a lot with the fact that the recommended safety policies and practices are increasing the costs and decreasing the revenue of these providers. For example, social distancing means you can serve fewer children per childcare classroom. And this increases the cost per child for a lot of things, including sanitation, screening, arrival and departure practices, where a teacher goes and walks the child back to the classroom so you don't have other adults wandering through. And then there's all the hand washing between all the activities, and all of that increases staffing needs. So between those big components, we're seeing a really different childcare funding model, and hearing a lot about financial support being needed to support the whole industry, open or closed, and to allow them to remain in business when childcare opens up again along with the economy. So a couple of additional challenges. The childcare market, as you know, is wide and varied. It's a market, not a program. It's a mix of public and privately funded children and programs that aren't coordinated by any single entity. In addition, as you all have noted, there's a gap. There's not a big reach out to childcare trauma experts, even though they are an allowable funded piece with childcare funding. It hasn't happened as much as you would expect, even though I think, as Deborah and others said, there's a lot more awareness of the brain science and the ACEs and all of that. I think it hasn't necessarily gotten translated into a use of the funding the way it could or should. Also, Office of Child Care doesn't have a mechanism for deploying volunteers to disaster sites, which is frustrating because we get a lot of calls and offers, but we aren't close enough to the action to be the ones to intervene, and that's troubling. And then finally, we're uncertain about how the pandemic will change our approach to disaster planning and response and recovery, including what we ask of states in their disaster plans. And overall, what kind of adjustments are we going to need to be able to address any future widespread health emergency? So we are open to learning from this conference and future work, and look forward to your questions and comments. Again, this is the same information memorandum, and then our general website listed on the final slide. So I hope I stayed within time.
Shannon, thank you very, very much. Great comments. Let's face it, everybody. We know that at the time of a disaster, it's all about response. But we also know that recovery, long and slow, requires flexibility, as Shannon said, and requires knowledge of where you can get the resources, especially supplementals, when you need those. So thank you very much. And thank you to ACF for sponsoring this conference and for lending us Shannon for just a few minutes. I'm told that our next speaker may be having some technical problems. Laura Lee Koziol, are you available, or do we need to skip? Laura Lee?
Oh,
and I see her. Hi, Laura Lee.
I'm here. Hi, I'm sorry.
Great to have you. Well, you know, we all turn to FEMA during these times of trouble, regardless of the problem. And when I was ESF 8 commanding officer for my region, for ESF 8, you know, my regular counterpart was just a couple of floors away, the regional director for FEMA. And so thank you very much, Laura Lee, and thank you, FEMA, for making her available today. She is the National Advisor on Children and Disasters with FEMA in the Department of Homeland Security. Take it away.
Thank you so much. And if we could you advance the slide on your end for me? Thank you. I'm afraid of my computer freezing up again. I apologize. So thank you so much. I'm Laura Lee Koziol. As Dr. Emily mentioned, I'm FEMA's Children's Advisor, and just wanted to talk for a few minutes today about some of the reoccurring themes that we've seen over the past 10 years during disasters when we're focusing on children, youth, and their families. So one being the need to address immediate and unmet needs, such as food and commodities, more specifically, the provision of infant formula, diapers, and wipes. Secondly, the reestablishment of infrastructure and support services, whether that be schools, childcare, other human services and support services. So any of those that truly allow parents and guardians to get back to work, and then also that help the economy to recover. And number three, the need for emotional and mental health support. So that has been a really big one, and it seems like it's gotten bigger over the past couple of years. It also seems that the children in need of these services has gotten lower. So I can only speak from my own experience, but that's something that has really been recognizable since, I'd say, 2016 or so. And then wanted to touch on the planning piece. You know, we always say disasters begin and end locally. I think that the disaster planning and preparedness piece is so key to that. It begins locally. And the stronger your plans are, the less you're going to need on the response and recovery side. So, you know, having strong and robust continuity of operations plans or COOP plans. So how are you going to resume your business once or immediately after the impact of the emergency or the disaster? How you're going to communicate with your staff and your clients when there's no electricity or internet for a short period of time or a long period of time. We saw that happen in a great magnitude during 2017. Emergency operations planning, or EOP. So how are you going to address your needs, the needs of your staff, the needs of the children and youth who are under your care? How are you going to communicate with the parents and the guardians of those children? And then do you have evacuation and reunification plans that you'll be able to use in the event that the children and youth are separated from their parents over the course of a few hours, or that may be for a much longer period of time? So do those plans include provisions for sheltering for an extended period of time? If the roads are damaged and the infrastructure is damaged, there are no communications, and you've got those children with you, some of whom may need medical care or critical medical care, and then recovery plans. So, you know, considering the idea of pre-identifying alternate locations that you might be able to use post-disaster so that you can resume your services quickly, whether it be, you know, again, through alternate facilities or partnering up with another key stakeholder within your community. Seen that happen quite a bit with schools. So having those conversations before the event so that you at least have options to start with if that should happen. And then also having an understanding, well, most importantly, having your insurance, any documents in an area where they won't be damaged by a disaster, but knowing what your deductibles are, knowing what your coverage is, having an idea of what documents you might want to submit, and then working and having a relationship with your local emergency manager so that if and when the time comes that you are looking for other resources, financial resources, knowing where that they may be able to, or who may be able to support you, such as the Small Business Administration, FEMA Public Assistance. As a private nonprofit provider, there are different provisions than there are for essential services or facilities such as schools and whatnot. So what are the different elements in terms of applying for assistance? And then one of the most important, one of the obvious common sense pieces, but collaboration. This one is so key. And over the past 10 years, many of us began working together back in 2009 in the planning pieces and development of how would we address children's needs and their families' needs as a whole. So not FEMA, not HHS, not Department of Ed and other nonprofits and private sector, but how do we do this together? And that has proven to be just so invaluable, but knowing who your partners are, having an understanding of their programs and how your programs may intersect in the event of a disaster, the chances are really good that post-disaster, that table of key stakeholders is going to be much larger than the table was pre-event because the need is going to be greater and you have to stretch a little bit in order to be able to accommodate the needs of the disaster survivors. And then, you know, as I just mentioned, having that trust and respect with one another so that you know, and we're really fortunate in that should something happen, we have that bucket of experts. So the ability to pick up the phone and call the Administration for Children and Families or the Red Cross, whomever it might be, and knowing that not only can we rely on them, but we can count on them. And there hasn't been one time that we weren't able to call at any time 24/7 and be able to receive that support. So that has come through some bruises and some smiles, but having that ability to really just see things from different perspectives and bring it all to the table together, because it's not about us, it's truly about those survivors. And with that, I will just thank you again so much for allowing us to be part of this panel today and turn it over to Dr. Himmler.
Well, thanks very much, Laura Lee. Great words and a great agency. So thank you, FEMA, for great support over many, many different types of disasters and emergencies. Our next speaker is Trevor Riggin, Senior Vice President, Disaster Cycle Services, American Red Cross. And what more can one say? Red Cross there since 1881 for all of us. And once again, a terrific organization, a major part of ESF 6, as we all know. And Trevor, take it away.
So just before I begin, I'm a little bit of the odd player. Maybe Dr. Markinson is the other one on the panel here. I'm a non-government person. I won't go deep into any policies or any grants or anything. This is really about the people we serve. I'll just share a few thoughts of where the Red Cross is focused right now, and then really look forward to some questions from everyone. So I'll talk about three things: kind of who we serve, how we serve, and how we're preparing in the face of disasters. And if you can go to the next slide, Mike. So I know that conversation today is really focused on during the disaster and after the disaster, but as a Red Crosser, I can't start any discussion without how we prepare, because that's, how we practice is how we play. And for us in the Red Cross, what we found, especially over the last decade, our children are probably our best opportunity to change the culture of preparedness in our country. They are the lever that will drive families. They are the catalyst sometimes to change the way we think about a crisis. And these three programs I have laid out here, the first one Prepare with Pedro is a program we've done with FEMA, and Laura Lee for the last several years been very successful in reaching younger children in schools. The Pillowcase Project was an effort built out of Hurricane Katrina when our leadership in Louisiana saw college students grabbing pillowcases to stuff their belongings in to rush away during the evacuation. We've used that as a calling charge for our youth, and we go into classrooms and teach about how to be prepared and how to stay safe, and also how to stay calm in a crisis. And then the last one is our Sound the Alarm effort, where we're installing smoke alarms in people's homes all across the country, but we're also educating them on how to get out in a crisis, how to get out of their home. And in all three of these, we have seen youth and children lead by example. I'll give one story. I used to be the regional executive for Northern California for the Red Cross and managed the team there. And one day I had the superintendent of schools from Dixon, California called me, and he said, 3 weeks ago, your volunteers were here and taught a classroom full of students, fifth graders, how to stay safe in a house fire. Yesterday, one of those kids' families called us to let us know that they had a house fire, and the only reason they got out was because their son, who'd had that class, stayed calm, reminded his parents what to do, and got them out safely. And you know, that applies to all these disasters. And I think much like Administrator Fugate years ago called on us to think about the whole community as a resource, we really need to think about our children as a resource in disasters as well. They are perhaps one of our greatest resources. Mike, if you can go to the next slide. So as was mentioned, this is what we're famous for, right? This is on the response side. It's what we do as the Red Cross. We play an enormous role in ESF 6 as a co-lead with FEMA in both providing and coordinating sheltering. We support individual and community feeding all across the country, distribution of supplies. What doesn't always make that list clearly is our health and mental health resources. Sometimes we focus so much on the tactical work of sheltering that people forget that inside that shelter, the care that actually happens is probably the most powerful element. In many cases, that's the health and mental health. If I was in a room with everyone on the call today and had an opportunity to share a little more personally, I would share a video with you of a family that I met, again, in Northern California that escaped from the fire in Paradise, the campfire. And they had taken a cell phone video that morning, early that morning. And in the video, you'd see as they're driving terrified through the debris and cars stranded, flames on both sides of the street. You could hear their children crying in the background, in the back seat. And the parents were struggling to remain calm. The mother was praying out loud. And the amazing part of that clip, though, is the last 10 seconds, as that car comes out of the smoke, nearly complete darkness, to these blue skies. And although that blue sky represented safety, what immediately came to mind for me as I saw that video was their next stop. So their next stop after that was probably a Red Cross shelter or some other safe haven. If you could imagine, now those children are not only have gone through the trauma of something you hope nobody ever has to go through, thinking they may die in a tragic accident. Now they're coming into an environment where their friends and family are there. They may think they're homeless all of a sudden. They may not understand what's going on. They see their parents struggling to have some sense of control. And that trauma, that experience is something we're using with our volunteers and our workers now on how we need to think about our children when we serve them in disasters. We have to understand where they're coming from. So much of our work as disaster experts focuses on scale, right? How do we shelter 10,000 people? How do we feed 1 million? But we're trying to drive our work back to that individual level to understand how do we serve that child and how do we understand what they're going through and the context that they're coming from, and create that space and flexibility in that work so our volunteers and workers can work individually with families and children to solve their problem in the moment and not treat it as one mass group. I think we see it all too often where we try to treat 100 people as 100 people and we miss the nuances that really could change the outcome for a child in a large disaster. You can go to the next slide, Mike. So long-term recovery. So the Red Cross has had a bit of an uneven role in long-term recovery in our history. We've, depending on the disaster, played a large role or a smaller role, but over the last 4 years, and probably most of us on the call today, the last 4 years are a bit of a watershed in the field we operate in, starting in 2016, 2017, 2018. We've really established a formal program for long-term recovery now. And when we have the funds available, which we are funded completely by donations from the American public, not through government operations, but through donations, We have established long-term recovery operations, and in addition to doing rounds of financial assistance for families, and we're still doing those in Hurricane Harvey, Hurricane Florence, Hurricane Irma, the California wildfires, Hurricane Maria, we've also established large grant programs. In fact, nearly a third, in some cases more than a third of the funding goes towards providing grants to other agencies who have more expertise in areas we simply don't. And that could be in the area of serving children. I just wanted to give three quick examples. On the left of the slide is in Hurricane Maria. It was a different disaster for us, and everybody was playing a little bit different role. So we took the funding we had, and we've actually been working, we're nearly done, in establishing solar panels on the tops of 125 schools and then another additional 30 to 40 community wells so that they will stay up and running even during a Category 5 hurricane. And over the last 2 years, the sites that have been up and running have continued to operate. Even as they've gone through earthquakes and storms, those schools have been operating. And as you may know, in Puerto Rico, the government actually runs the shelters in a disaster, not the Red Cross, but they typically do it in the schools. And we want to make sure those schools are a safe place, not only for the families that come there post-disaster, but also for the children that need to be there and get back to school as quickly as possible in recovery. And these solar panels will both keep power going, but also keep potable water safe for all those families. It's a huge investment we made, more than $40 million in investment in Puerto Rico over the last 4 years. The middle one, this is in Hurricane Harvey, just an example of a type of grant we provided. This was to Hope Worldwide to provide 8-week therapeutic performing arts programs for children who were impacted directly by Hurricane Harvey in critical and vulnerable neighborhoods all across Texas. And we all know the positive outcomes of those types of services. And so we think it's a great role for us to play into helping to shepherd donor dollars to organizations like Hope Worldwide. And then the third one is around healthcare. And in many cases, this was focused on children. This was in California. And for families and children who may not have had access to dental and vision care, we provided a large grant to a group called the California Care Force, who brought in volunteer medical professionals who are now providing health care to families and children who otherwise wouldn't have had it. You know, they may not have had it before the disaster, but so many families lost it after the disaster because they either their jobs were lost, their businesses were lost, or they simply didn't have the funding. And so we believe this type of recovery work can make a huge difference. Next slide, Mike. Last slide. This again just speaks to the values we're trying to instill in our workforce. So this is Destiny. I didn't meet Destiny personally, but a colleague of mine did in a disaster last spring. This was during Hurricane Dorian along the East Coast. And Destiny was in a shelter with her family in North Carolina or in Georgia. And when my colleague actually met her, Destiny was peering out from beneath the covers of her cot. She was talking to her parents, and Destiny was there. Destiny's 10 years old, and Destiny was there, but she was hiding under the covers. And she wasn't hiding just because she didn't want to be around people. She was hiding because she had sensory overload. Because of a condition, the shelter simply was too much for her. And I think we see that way too often in children where the noise and chaos of a shelter or any other environment is simply too much. And Destiny was struggling to handle that. And her parents were focused on so many other things that they may not have had the resources or the time because they were trying to figure out what to do for their family. Thankfully, because we had sensory kits in that shelter, we were able to provide Destiny with a weighted blanket and a stress ball, headphones so she could listen to music and drown out the other sound. And amazingly, you know, within the next few hours, we saw a complete turnaround in Destiny. And it's just one example. And I know it may seem like a simple one, but what it does for me is exactly what it says on the right. This is about being responsive to individual needs and values. This is not about how many meals we can bring into a shelter. This is about understanding people's condition, understanding both their needs, but also what they know, right? The skills and experience they've had, and give them some power and authority over that experience and have them bring that to service delivery and self-determination. So, you know, I'd ask you to remember the story of Destiny as you think about how we serve people. Remember, this always comes back to a person or a child. And Robert, I'll turn it back to you.
Yeah, absolutely, Trevor. And thank you so much for that real, you know, there's nothing like when you put a child's face in front of a policy. It brings it home for all of us, doesn't it? Because it's really all about being able to provide children and youth adequate human and social services That's what this is all about in this workshop. We'll move on to our next and actually final speaker of this panel, Dr. David Markinson, who, like me, is a pediatrician by training and a specialist. He is actually a specialist in pediatric critical care. He is also the founding director and the medical director at New York Medical College of our Center of Excellence in Precision Responses to Bioterrorism and Natural Disasters. Dr. Markinson.
Thank you for this opportunity to present. As Dr. Amler pointed out, I work at the New York Medical College Center for Disaster Medicine as the director. I am a pediatric emergency medicine, pediatric critical care physician. My research is conducted through New York Medical College, and I obviously have some overlap, as many of you have seen in my bio, with Trevor at the American Red Cross, where I serve as the Chief Medical Officer for Training Services and chair the Scientific Advisory Council. As Trevor alluded to, I am not one of the federal presenters. I work in the private sector, both for the American Red Cross and conducting research with New York Medical College. And as such, my focus will be a little bit different than some of the other presenters. Many of the presenters have talked about what their agencies are doing so well to help address children's needs and some of the challenges there. I'm going to sort of step back and look at it from what I've seen in my world of disaster medicine and disaster planning for these past couple decades, and really talk about the challenges that exist in the planning system, response, mitigation, recovery, and the ones that still exist and where we need to go. And I'm going to try to put them in several buckets of either healthcare, child congregate, and then some overall system considerations. Really, in general, I think a lot of the problem with planning for pediatrics starts from a statement and quote I hear over and over and over. And while I hear this quote less these days, unfortunately, I'm still hearing it. Don't worry, we'll plan for the population, and then later we'll deal with special populations. Now, there are two problems there. One, later never seems to occur. And two, the people that they're talking about in later are part of the population. During some recent data, at least 26% of the US population are children and youth, and that number varies from 25 to 30s depending on how the cutoff points are drawn. More than 20 million are under the age of 6 years, and a lot of those are infants, which is, as you can imagine, have very unique challenges. Most of the preceding planning and research really focused on adults, and a lot of it came out of military research, especially when you think about environmental and especially terrorism, and thus it doesn't include data on pediatrics. And in general, whether it's pharmaceutical research, medical research, population research, usually it focuses on adults first because of many considerations for planning, preparedness, access, and as such, the data isn't always there. And in the absence of data, people say, well, let's just not plan. In addition, for many reasons, many key pediatric sectors were not included in the process. For example, years ago at the federal level, when they assigned agencies part of the federal response planning system, and this has evolved over years, I'm just giving you some of the historical context, operational entities were giving a role in the planning. But for example, Department of Education, which is primarily a grant funding agency to education entities at the time, wasn't part of the planning process. There was no primary role. Lastly, if we think about challenges of children, even if people start to plan for children, children with special health care needs are never included in that process. Whether it's medical, mental health, access, all the issues you could think about, they aren't part of it. And this sort of sets up the context for some of the challenges that we face. When you look at healthcare, it's really all about two words, capability and capacity. If you go back several decades, EMS had almost no capability for children. That has markedly improved, but their capability can be quickly exhausted in a time of challenge. Their pediatric specialty transport teams may be 2 or 3, but if they're linked with the hospital, such as a major hospital taking out or inaccessible by a hurricane or tornado, we can look at Katrina, Joplin, go right down the list, they're no longer available. hospital capability. With the advent of children's hospitals that have greatly advanced the care of children, we've also created a disaster gap. Because what has happened is, as capacity and capability in children's hospitals has increased, capacity and capability in other hospitals that are non-children's has decreased. So what if the hurricane, tornado, electrical, pick any natural disaster you want, wildfire, has taken the children's hospital, the one in town, the one in city, or in most parts of the country, the one in a region, out? What is the capacity and capability of hospitals? And so it's incumbent upon all hospitals to have the capability in a disaster to handle the needs of children. We also then have to think about specialty. We know burn care is limited in this country, and we've always talked about in disasters that there's almost none available. What about pediatric burn capability? In our recovery phase, I, as a critical care physician, struggle every day to find rehabilitation facilities for children. What happens when the system is taxed? The numbers are increased. And for all these elements, if we're struggling during normal times to have the capacity for several children, what is our surge? In some communities, an event that injured 4 to 5 children simultaneously would exceed their capacity and would be considered a mass casualty incident, where an event would have to be in the hundreds in that same town to be considered a mass casualty and compromise the care of adults. An area that I think gets almost no attention and we need to think about is child congregate facilities. Children spend much of their awake time at school or other child congregate facilities. In recent times, we're hearing about business planning, business emergency planning, business continuity of operations planning. I have failed to hear an equivalent term, message, resource discussion about child congregate facilities. We recognize that adults spend the majority of awake hours out of their home, but we have failed to recognize that children spend the majority of awake hours away from the home and have parallel processing planning for them. As an example, where systems can fail very quickly. When we've surveyed this and looked at this, few parents know the emergency plan for their child's school. We know from studies and reality of Joplin, Katrina, Marie, Irma, go right down the list, that the majority of adults will disregard official emergency plans, evacuation discussions, and head directly to where their child is. Even in the setting where their child is, may have a plan to take their child from there to a place of safety for reunification. And so we have parents going against orders to get to their kids, disrupting child movement, even in the setting of good plans, but the setting of good plans may be rare. As a result, these social realities of lack of communication planning must be addressed, or your entire plan for a community can fail. So what about the child congregate facilities? If we look at schools, while it has improved, they are still woefully lacking and there are still significant challenges. One of my favorite stories I tell that I get repeated over and over when I look at different communities is I go into the emergency management office and I say, can you explain to me where you are likely to put shelters if you need to create a shelter in a community? And schools are always either 1, 2, or 3 on the list. I then have a separate meeting with the school officials and say, if a natural disaster occurs in your community, what are you supposed to do with the kids? And the answer is evacuate the schools and send them home. So picture the resources. We have an announcement that an event is happening. At some point, middle of the day, others are moved out of their school to home. And then we take additional resources to bring that family unit back from home to the school. An example. But schools at least have some planning. When you get to child congregate facilities, there is almost none. Camps, after school, religious programs, largely not planned, few resources. And then if you look at the system, Here are the challenges we have. Very few pediatric specific supplies and resources, and our FEMA representatives talked about how we've gotten better, but things like diaper, formula are missing. We don't think of planning as a family unit, and no family is going to allow themselves to be separated under routine times, but definitely not in a disaster. We have assumption of family planning, as I said, for population first and others second. How do we reunify with the recognition that parents are at work, children are at congregate facilities during the day? How do we ensure when they can't be together, they're put back together? And how do we coordinate amongst all the sectors? Local, state, and federal resources all need to have pediatric-specific plans, resources, tools. At the federal level, we can look at making sure that there's the appropriate focus and expertise, and things like DMATs and Strategic National Stockpile have the necessary pediatric resources and supplies. There are many recent examples, and I could go through each one that gives you an example of what it is. Katrina, Harvey, wildfires, Joplin, Flint, H1N1, and now with COVID. Luckily, that hasn't affected children the way other viruses do, but it still has affected, and we only found out late in the game some of the unique effects because it wasn't looked at. So again, these recent examples just prove home, and hopefully what I've done is just lay out some of the challenges, but also I always like to think of challenges as opportunities for improvement, and these are all clear opportunities for improvement. And at that, I will conclude and hand it back, stop my sharing, and hand it back to Dr. Amler, our moderator.
Well, thank you very much, David, and thank you to all the presenters. I'm sorry that Madeline Sullivan was not able to join us, but I believe that Roberta, you're going to lead us through some of the questions, and it's nice to see Laura on the screen as well. Hi, Laura. So here we are. Roberta?
I will actually be posing the questions from the Q&A box, and this is just a reminder to participants, if you want to submit a question, you can do so using the Q&A function in Zoom. So our first question is for from Patricia Frost. How do we right-size the systemic culture of adults over children in the emergency management hospital and first responder communities?
So Dr. Markinson may want to start with that one.
Thank you so much. And obviously, thank you, Patricia, for that question, Ms. Frost. We've obviously had some of these discussions well in the past. I think it all starts with the concept of what people view as the population. And the concept that the population is often adult males from 18 to about 55 is, I think, where the problem starts. If one recognized that at least 25 to 26%, in some studies 30% of the population was children and youth, and whether you're a state, local, federal planner, responder organization, and you have a legal responsibility to plan, by definition, 30% of your effort, time, and resources should be directed at children or youth. So it really starts with the obligation is to be prepared for the population and a recognition of the size of children and youth.
Thank you. And we'll move on to the next question.
Great. We have a question for Laura Lee. Across your involvement in the federal response to Katrina and tornadoes in Joplin and Moore to Sandy and Maria, have you seen any changes in how federal emergency managers work to identify and support the needs of children during response?
Thank you, Laura. Yes, without any question. I would say it's definitely been an evolution. So we really began, I'll speak from the FEMA perspective. We didn't begin focusing so much on children until 2009, 2010. And so the approach that we had taken was to build many resources throughout our programs and then partnering with other, whether it be governmental, like Health and Human Services, Department of Ed, what have you. So I'm a little bit too honest sometimes, and I will say that there were times when I wasn't so sure that, yes, we were doing so, or that the efforts had been intensifying, but I feel very confident in today saying that, yes, there's no question. We have a long way to go, especially when it comes to training and further socialization, but we've come further than I had imagined, ever believing that we would, if it were even 2 years ago or so.
Thank you, and we'll move on to the next question.
Sure. Thank you. This is from an anonymous attendee. Have you seen a shift in the awareness of the importance of emergency preparedness and planning among either child care providers or lead state agencies for child care following the changes to the CCDF requiring them to develop emergency plans?
Is Shannon still here? I don't see you on the screen. Can you respond?
I'm still here. Can you hear me?
Okay.
Okay. I think that we have seen it. Since we had the requirement, which got to have a disaster plan, which became stronger in the 2014 reauthorization that we did, we have seen a few states that have asked to update their disaster plans. And we also now look at the disaster plans as part of our on-site monitoring process, which brings more attention to them. We also do a whole lot of well-attended training when we have conferences. And of course, we're going to have to add new training. And I think COVID has gotten people a lot more interested because whatever they were doing before wasn't enough for this. So we have seen some, and I expect we'll see more.
And then Shannon, as a follow-up, a question from a previous session, who's responsible for assessing childcare facilities to make sure they're safe for children and staff to return? And then can you also speak to the centrality and importance of restoration and continuity of childcare after disaster?
Yeah, the safety of the facilities is not a federal responsibility. It's either state or local, depending on what's being looked at, probably local. And the centrality of the continuity of childcare, I think we all agree that childcare is a key to recovery when there's an emergency. And even if on a natural disaster, the scope is smaller than it is with what we're experiencing now with COVID by a lot, the affected families and providers need childcare, both so they're, even if it's not in the same facility, there's a need for childcare to cover a lot of children sometimes while their parents are dealing with what's left of their home or going through the paperwork process and standing in lines and all that. So sometimes we see it occurring at the disaster site itself, some of which may have some of our funding. A lot of it is Red Cross and others, but also just getting the regular childcare up and running is really important, and completely agree it's central. And the piece is about realizing that the teachers and the children may be traumatized, and it can't just even be business as usual. It's extra supports and training needed for that.
Thank you very much. And Laura, do we have time for one or two more questions?
Yes, I believe we do. This one is for Dr. Markinson. Do you have any suggestions for communicating with parents and guardians about reunification if the strategies are not currently working?
And I'd like to hear Trevor's response as well.
Yes, so I think part of it is just communicating the plan. I can tell you as a parent of children in different age schools, elementary, middle, and high school over the last few years, as well as someone who goes in. Nowhere in orientation or during the year do I get any information on what would happen in an emergency. Because if my social and behavioral goal is I am going to get to my child no matter what, and I knew there was a plan that that child would be moved from this school to this place, and the only way to be reunified with them is if I knew that I'd be told through this channel where to find them, that's where I'm going. So to me, step one is communication. Step two is communication. Step three is communication. Trevor?
Yeah, David and I are in total alignment on this one. I think post-Katrina and a few other events, we all drifted towards a lot of technology for reunification. And although technology is useful and helpful, it can somewhat blind us to just the simple challenges of staying connected and communicating expectations and setting up the system, the plan ahead of time, making sure parents and families understand what that plan is, and even the children understand what that plan is, or the youth understand, and so that everybody's on the same page on where you go to reunify, what that messaging will look like. If you get a text, that you know that it's valid, that it's real. And so I think very clear plans. I think all the tools we have Safe and Well website, even using Facebook or other social media is helpful, but you have to understand the formal plan. So when you get into a crisis where information could be misused, or where there's a very real threat to families, that's where it's so critical that we are following the real plan for reunify. So I completely agree with Dr. Markinson, communicating that well ahead of time, making sure people fully understand and have access to it on a regular basis, not just the beginning of the year, but throughout the year, to make sure we're reminding each other what that reunification strategy is.
Thank you both. A very important question. Yes, Shannon.
I have a question for Trevor. Mm-hmm. Do your Red Cross teams stay in touch with or know how to access the individual providers in some way so that you know what their personal plan for reunifying children with parents if the disaster occurred during a child care day is? Because they all are required to do that. So I'm just wondering, how does that piece stay coordinated?
So it depends on where it is in the country and what the sophistication of the network is. We usually try to partner with an agency that has tentacles out into a lot of different providers so that we can stay connected. When we have extended sheltering, most of our shelters are open for 24, 36 hours typically, but when we have extended sheltering, like we've seen in recent large-scale disasters, in California we have one open for 99 days. In Texas they're open for about 65 days. That is when we do start collecting from the families that information and do outreach on their behalf, if they can't do it, to providers, just to see what their plan is, if they can start providing child care again. So that usually happens through our health services workers, so that they're just used to handling confidential information, working through channels and processes. Our nurses are very good about handling that process. We've learned a lot from working with people like Laura Lee over the years on how to do this in the right way and how to stay focused on the important tasks.
Well, this has been an amazing panel. We are now at the bottom of the hour, regardless of which time zone you're in, coast to coast. And that means it's time for a quick lunch break.